you guys are good to go.
Okay, hello everyone. Welcome back to another virtual shadowing session with Fresh Dental Shadowing. Thank you for Dr. Raylien Chao for coming out. She's a pediatric dentist and she's just going to share a bit about that specialty. So you could go ahead whenever you're ready, Dr. Chao.
Okay, hi everyone. I'm excited that you're interested in dentistry, and pedo if better, Well, but dentistry has 9 different specialties, and they all have their, we all have our hearts in different areas. So I'm just gonna go ahead and start. Today we'll be focusing on baby teeth, and most of the things that I encounter almost on a daily basis, where parents ask me, or things that I see all the time. Just a quick intro. I have 2 accounts. Dear Dr. True Story, I'm posting quite a lot of educational stuff on there, and Kiddo Smile is just the office that I just recently opened. I'll just very, very quickly go through my journey. So I grew up in Taiwan until 20 years old. I transferred to the States in Wisconsin-Madison, Go Badger, for my college degree. And after that, because I majored in economics, so you can go into dentistry with any major. I have friends that major in engineer, teaching, dancing, arts, all kinds of different majors. So you just really do where your hearts are, and if you really want to do dentistry, you can do your prerequisites on top of it. That's fine too. And then after that, I went to New York to complete a human nutrition master degree in Columbia University, just because I'm changing from the finance area to science area, and I do really need those basic stuff to get me going. And then I got into dental school at University of Minnesota, and I also founded our American Association of Public Health Dentistry chapter when I was there. And I also was a exchange dental student to Denmark Aarhus University Dental School in my 3rd year. That was a great time, great experience. And today I live in Vancouver with my husband and two little kids. So an outline for today's presentation, we'll be talking about obviously baby teeth, teething, and what's the differences between baby versus permanent teeth. The questions and stuff that I see all the time during eruptions, and why are baby teeth so important, and how do we usually treat cavities in baby teeth. Dietary recommendations for young kids, young families, and tips for daily oral care. So on the left side, you can see this little picture. The eruption sequence for baby teeth are the central, the lateral, and then it jumps to the first baby molar. So usually you'll see a big gap when the molar erupts. That's because the canine comes after the first baby molar. And then by about 2.5 to 3 are the second baby molar's eruption time. So baby dentition includes 20 teeth in total. And another big important thing is timing can vary by child. So you can see on the left side, there's a big range for the reference. Normally people say, okay, the first tooth should erupt around 6 months age, but we've seen kids born with teeth. Those are called natal teeth. The latest I've seen a baby without any tooth is about 17 to 18 months. So that's a big range. And really, our body doesn't read textbooks, so a reference is just a reference. It's like kind of like you have an average height and weight for this class or this age, but everybody is at a different point. So you can tell parents you don't have to worry too much if your child doesn't necessarily following the reference, as long as if it's by age 1, you have any questions or anything, start seeing a pediatric dentist and have the pediatric dentist follow through and monitor your child's oral care. So we talked about that. Gaps in between baby teeth are very, very normal. A lot of people ask me, why do we need to get braces at such a young age, where my kid is 3, has so many gaps? I tell them, gaps are like money in your bank, you're gonna use it later. Gaps are good stuff that you want to have because the front teeth in permanent dentition, the incisors, or what we call front teeth, are much bigger and wider than the baby front teeth. So gaps are good. It's going to be occupied later. And especially during the early transition, so around 6 to 9 years old, your adult teeth comes in the front, but the jaw and the growth or not has not caught up yet. So you'll see that early transition, the awkward little crowding that's going to be presenting. And around 9 years old, it's when the lower canine erupts, and that will increase the width of the jaw. So that's going to come later. So baby teeth usually, on average, comes in between six months to 3 years old. So common things we see with teething, including drooling, a little bit of rash on the cheek, some discomfort for sure. But, reflux, question mark, no direct proof from the science. Diarrhea, commonly seen, but also not linked and proved by the science. But one thing I can tell you is a child is never going to have true high fever when they're teething. But a lot of time, because when young kids, they're teething and kids went through an oral phase. Mouth is where they're going to explore, learn things. That's why they're sucking. Little young baby can most of them do either finger or the pacifier, and that's normal and safe in the first 6 months. They need that for their safety. It's just that's what's happening. So during teething, a lot of times what you could kind of see but not cause associated is a little bit of sickness or light fever. It's because kids grab things and they put it in their mouth. They want to chew. So there's other bacteria or viruses that they can introduce to their mouth and kind of causing other things that you may see. But teething itself never caused true fever. When it comes to the last resort, let's talk about the left side. I have a couple items here or pictures here. You can put either a pacifier if your baby is taking some, or the utensils they're used to, or if after 6 months your kids are start taking solids, you can do their snack, their favorite snack, either puree or your own breast milk, to put it in the ice cube form or trays, and create some long stick things, ice cubes or ice whatever for them to chew on. You can even put their favorite teether in the freezer to make it cold. You can roll a wet cloth with the little wet cloth, put it in the freezer as well to make them chew, and that will massage their gum and release a little bit of symptom as well. But during nighttime, like my older two of my kids, they all had multiple teeth came in at the same time. I call it popcorn eruption. Came in, boom, 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 and oh my God, there's definitely a week to two during nighttime. They scream and they just couldn't sleep. So what do we do then, right? During the day, you can distract them with toys or other things, but at nighttime, your kids, or mostly you or the parents want to get some rest and sleep as well. The last resort we talked about is by the guideline is usually systemic Tylenol. But I listed this camellia is a lot of family will ask me because it's over the counter. It's more herbal if you truly want to compare this. It's kind of like the Western medicine versus, the herbal medicine. There's no scientific proof if it's actually helpful, but in my practice, I see about half and half of them say, it's working, it's sort of working, I don't know, and you think that may be a placebo effect sometimes, or it may really be working, you don't know, right? So if some family asks you about this, you can say, hey, by the guideline, we do recommend Tylenol, but if you want to try herbal camellia, just use it based on the instructions. Don't go overloaded, don't overdosing, just really following it. And for Tylenol for young kids, it's dosing by weight. So you have to remind the family also don't overdose it. and make sure you check on the concentration, because each medicine or brands doesn't come with the same concentration. So you can't just say 5 cc or whatever. Just look at the instructions on the box and dose based on weight. So we're gonna go through a couple of things that I see pretty commonly for eruptions of the baby teeth and the adult teeth as well. So first thing is eruption cyst. So this presents just like the picture on the left side. You can see a swelling kind of purple bluish color, and if you touch it, it's soft and fluid filled. Usually it self-resolved, so we don't need to do any treatment for active involvement or interventions. What we can tell the parents to do is just massaging the gum or use all the other stuff that I mentioned earlier to help kids bite on and relieve the symptom. Most of the kids, when they have eruption cyst, they're fine. They're eating fine. They're acting fine. It's usually incidental finding. The parents were, if they have a few teeth, I ask them to really start brushing, and they look into it, and then they're, whoa, what's that? So before looking, most of the family don't even see it. Okay, so other situation that we could see in baby dentition is extra tooth, fused teeth, staining, or calculus. Calculus is not as common, but we do see them. I do see them as young as 1 year old. So let's look at the upper right picture. So if you look at the midline, it's right here, and the lower midline is to the left of the picture. So why is there a midline deviation? So this yellow arrow points to this big white tooth, white tooth. So you can see if we count on this side to the canine, it's 1, 2, and canine is number 3. And on the left of the picture, it's big, and number 2 is the canine. So this white tooth is 2 fused into 1. Sometimes there's gemination, which means 1 tooth budded into 2. So the different how you tell gemination from fusion is by counting the teeth. So if this is gemination, you will still count canine as the number 3 tooth on this quadrant, because we situation. Let's look at the top. To the left, I have 1, 2, 3, and 4 is the canine. So you know that there's an extra tooth here. So always, when you assess a patient, don't jump into the teeth first. You're looking at the patient as a whole. Look at the big picture. Count the teeth first, and look at I'm not going to go into reading x-rays and stuff, but when you look at a pen, a big head and neck x-ray, that's also the first thing you'll see is assess the big picture, the jaw, the ear, the border of the mandible, the jaw, and stuff like that. Yeah. Okay, so staining, I see that quite often because in Vancouver, we're a big portion of our population is Asian descent, and there's also no proof of why we do see staining so often. Some studies say that it's because of the rice that Asian population is heavy, or diet is heavily based on rice. Some kinds of rice are iron fortified, and if your child has the right bacteria that can use the iron and produce sulfate byproducts, then you may see more staining. But there's really no cause or study that really prove why staining happens often. What I usually suggest the parent to do is to switch to electric toothbrush, and also it depends on where the staining is showing up. If it's at the gum line, and I just tell them I demonstrate how to targeting brushing the gum line. If it's in between, then I say we really need to follow the C shape in between the teeth to get the line angles cleaned. Some situation, maybe because the oral environment, the bacteria is really just more corneogenic, then sometimes I do suggest more frequent cleaning, frequent visit every 3 months, or I ask them to use warm water with a little baking soda to brush occasionally at home to be a little bit more abrasive. But But most of the kids, when they have staining, they do outgrow it slowly. So that's interesting. Other situation besides extra or fusion or budding of the teeth, you may see missing teeth. So I mentioned that gaps are normal, but if you see significant gaps, then you want to take an x-ray and see what's going on. Right? If it's truly missing a tooth, you see how right here there's no lateral and there's no lateral on the x-ray as well. Same thing on the bottom right here. Okay, missing tooth may be one reason why there's a big gap. Other reason may be an extra permanent tooth, right? We call it the mesiodent, but not necessarily. So we really do need to, take an x-ray and figure out what we're dealing with. So one question I get asked almost daily is, when do we start flossing? My answer is as soon as you see two teeth touching. So it doesn't have to be 2-year-old or whatever age. Some people or kids, when the first two lower front teeth are brought, it's overlapping already. So it really depends on the dentition. Trauma is so common in kids younger than 3 because they're wobbly, they're learning. The 2 to 3-year-old, they're out there, they just want to go. So one of the common trauma we see on the left picture is intrusion, meaning the tooth, when the kid fell, got pushed into the gum. So it depends on how severe it is, but normally this common situation that we see, we wait and monitor a month for the tooth to re-erupt. This is also one of the situation where it has the highest chance to damage the adult developing tooth underneath. And I can talk forever, but in a normal situation, when I see this, I tell the parents what to expect in the future. The adult tooth may change color, So the middle case is a thumb sucking patient. So not all the sucking habits, either pacifier or finger, will change the form of the jaw or the angulation of the teeth, but some do. So it depends on the severity, the strength the kid is sucking, the frequency, and also the total time that they're sucking in a day. That all play a role in whether or not they're going to change their jaw. So in this case, it's a severe case. So you see the upper front teeth are really budding out, sticking out. And if you look at the first picture, you can see narrowing of the jaw in the front. Those are all common things that we see with the prolonged sucking habit. But I listed in trauma because when this dental changes is observed, the horizontal distance, so the distance between the upper and the lower teeth, the edge of the teeth, also increased. So your upper front teeth is kind of singled out there. So when the kid fell, it also increased their trauma risk. On the right side, I listed an x-ray because sometimes it may not seem like there's any damage or trauma to the teeth from the outside, but at the routine care, you take an x-ray, you see, okay, so this black line means there's a horizontal fracture on the root tip over there. So, and then we'll talk about this findings and what to expect in the future as well. So yeah, so we really do need x-rays. So a lot of parents are like, oh, my kid's teeth looks just fine, I don't need x-ray. Then we have to inform them what's the potential outcome if you decline an x-ray. And obviously if they decline x-ray for a prolonged period of time, then you want to protect your license, right? You also can't just treat and some things can be missed without an x-ray. Even cavity as well. I'll show you some pictures later on. So one other thing that's so common is proxima, attrition or grinding of the teeth. About 30, and some studies said up to 50-60% of the kids younger than 6 are grinding in various degrees. So you can see this flat line across the front teeth. That's a sign of grinding, or in dental term is attrition or bruxism. But most of the kids, I would say probably 99.9% of the kids who are grinding does not have any sensitivity or symptom either, because the nerve in the baby teeth are very responsive. So once the surface are starting to be grind down, the nerve is also receding as well. Unless the grinding is so severe and aggressive, and the nerve is not, it doesn't give the nerve enough time to recede, then very rarely we do see abscess, which is irritation of the nerve causing by grinding. Okay, so another quite interesting thing we see, or I hear from the parents, is when the kid is around 6 years old, the first permanent erupts behind all the baby teeth, and they'll be like, I'll be telling parents, oh, your little Johnny has a new tooth in the back, and the parent will be like, what? But he didn't lose any tooth, right? So that's one thing most of the parents don't know. Yeah, it's quite interesting. But to let you know, all the permanent molars, they do not replace baby teeth at all. So they come behind, and as we grow, the mandible, the lower jaw, will have more width in the back, and that's how we accommodate more teeth as we grow. Okay, so major differences between anatomy-wise between permanent and baby teeth. So let's look at the left side is our baby tooth. The neck of the baby tooth is more constricted, like you see almost a heart shaped, right? Versus on the adult tooth, it's more horizontal. So from the crown to the roots, it's more similar to two straight line. Versus in baby teeth, the neck of the tooth is really narrowing down. And that plays a role in terms of our filling. When we do an L-shaped filling on the side, at the depth of the box, you don't have enough width. So that comes in play, in terms of why larger decay, we choose to crown them in baby teeth instead of large white fillings like in adult teeth. Another thing is rising of the nerves and larger in proportion. So you see how the tip of the nerve there, it kind of follows the contour of the outline on the top, the cusp tips, very well. And in kids, so this picture, the two pulp horn is the tip of the nerve. Seems like they're in equal height, but in reality, most of the cases, especially the first baby molar, they have a really high pulp horn, goes very close to the surface of the tooth. Okay. And the cavity do grow faster on baby teeth as well. More accessory canals, meaning, so when you see infection on the x-ray in baby teeth, you see the shadow, what we call the radiolucency, in between the roots at the furcation area. Versus in adult teeth, you will see it at the tip of the roots, because there's not much accessory canal, and the infection goes from the crown all the way to the tip of the root. But in baby teeth, we do have a lot of little accessory canal that connects to the center area. So most of the time when you see infection in baby teeth, it's showing up in the center, in between the roots. The roots are more divergent, more like this, okay? And the adult tooth buds are usually, for the molars, are usually sitting right here at the center of the furcation area. That's why. So when you extract a baby tooth, it's a little bit difficulty, because it's more, when roots are more divergent, it's more retentive per se, right? Versus in adult teeth, the roots are relatively more parallel. Oh, one thing is adult teeth, if you put them side by side, I'll show you a picture later as well, they appear darker. It's because the denting layer is darker in proportion in adult teeth versus in baby teeth. So transition, let's see. So we talked about in the early transition, gaps are great because adult front teeth, incisor and the canines are wider than the baby teeth, and textbook actually literally calls it an ugly duckling stage, because things are going to change later, right? We talked about the jaw is going to grow, right? The size of the teeth are not going to change, but a kid's face is going to change a lot. So it depends on the severity or the millimeters we measure that they are having this, early crowding. Some you say, hey, the growth will, change all this. Don't worry about it. Some say, okay, we probably do need to refer little Johnny to start seeing orthodontist a little bit earlier, and then we can, plan accordingly. Some situation we are able to do things along the way to help alleviate the future crowding. But some you just, take a look and say, okay, this could be dealt with at the end of the transition. But the American Association of Orthodontists, they do recommend the first ortho visit by age 7. But you can tell parents, I refer you to see an orthodontist for a consultation, but it doesn't necessarily mean that little Johnny is going to get braces right away, right? Consultation is another way to follow up, and the orthodontist can discuss more in terms of growth and development and why they're monitoring, what they're monitoring, option ABC, and the timing to start treatment and stuff like that. So it's really good to have a team that you're working with, an orthodontist that then you agree with the philosophy. But general rule is you can start refer to ortho for an evaluation around 6 years old. Sharp teeth. So this is one thing that we see so common. If you think of the teeth as an iceberg, you really just see the crown of the teeth, but the root is quite long. So in baby dentition, the first adult tooth comes around 6, but they really start forming right at birth, right? The tooth buds and enamel and calcifying starts right at birth. So there's no room. So our jaw is this tall. If your tooth has a crown and the roots almost to the end of the jaw, where do you have room for the adult tooth to form? So they do form slightly overlap like that. So it's normal for an adult tooth to come slightly, what we call towards the tongue or lingual to the baby tooth. What we cared about is if the baby tooth is mobile or not when you see that second row of tooth, right? If it is indeed very mobile, then you know the adult tooth not only has an upper eruption force, but also has enough forward eruption force that it's slowly pushing out the baby tooth. So if it's showing to roll and you see that the baby tooth is very wiggly, then I tell the parents, just help with little Johnny, be creative, and it'll be a fun experience, right? But in a situation where I may help is if a child is super sensitive, super careful, not even wanting to go anywhere near the mobile tooth, then I help them. If little Johnny is not able to eat very well, eat normal, is afraid to touch the area, then I say, okay, I can help you. But otherwise, normal situation, if it's mobile, then I let the family work on it. Sometimes I do see adult tooth comes behind, showing internal situation, and the baby tooth is rock solid, right? So then okay, it really doesn't have enough forward forces, then let's give it some help. So I talked about the ortho recommendation around 7 to 8. So another common thing we see in mixed dentition is diastema, meaning the gaps in between the teeth, right? So very commonly it refers to the upper center midline. And studies have shown that if the gap in between the center midline is within 2 millimeters, 80% of them do self-close. So the timing that we monitor and wait is usually wait until the upper canine erupts around 11 to 12 years old. So then we tell parents, right, gaps are normal in baby dentition. Also during early transition, it's common, not to worry. Unless if a child is having some self-esteem problem, getting bullied or having social problem, or really think that some girls do care about those quite a lot. So sure, we can do phase 1 ortho treatment to close it, but in reality is it's not gonna affect anything in the future, right? It could be closed later on in phase 2 as well, comprehensive phase as well. mamelon is a term that we describe the wavy edges of the teeth of all the incisors. So all teeth have this growth center. I think it's so long ago that we learned about these, but it's about 4 or 5 lobes comes together. So these little wavy thing, one of each little bump is one growth lobe. We all had it when we were little, and with function and time, it just slowly gets going down to nowadays what we think looks beautiful. But when it first erupts, mamelon is very normal. So we talked about the front teeth, incisors, canines. The permanent teeth are wider than baby teeth. Comes to the molars. So baby molars are wider than the premolars, right? So premolars replace the baby molars, and premolars are slightly narrower. So there's a little bit of a space that we could gain from the transition. So if your front teeth are truly very crowded, then you know, okay, I not only have gaps in between the baby front teeth that I can occupy, but also later on during 10 to 11, when we change the baby molars, I will also gain a little bit more in the back as well. Ectopic eruption is also quite common. So it's when the first permanent molar erupts, it doesn't go straight down. It kind of tilted a little bit more towards the front and get slightly wedged under the crown of the second baby molars. So 2/3 of the time when you see ectopic eruption, it self-corrects by age 8. So we do monitor this routinely. So I'll show you a case, this very left picture. When we first saw this, you can see it's quite wedged, right? However, it is self-corrected. So this middle picture is the follow-up of that left case without any intervention. But sometimes, like on the right side, this gets worse and worse, and you monitor and the kid is closer to 8 and it's really not coming together, then we intervene. So another thing, like in the middle picture here. So okay, the tooth self-corrected now, but there was resorption. There was indeed a resorption and a shadow here. What do we do about it? Is the tooth going to survive? Yes, it is. Very funny, but it very rarely requires intervention, and tooth stays healthy, right? Our body is amazing. So on the right case, sometimes the premolars or the front teeth, depends on the crowding situation, can go towards the cheek side or towards the tongue side as well. Those are common. So we in this situation on the right side, we do need to pick it up right away and help remove the baby teeth or tooth as soon as we can. So there's enough eruption forces to kind of still self-correct it as it erupts. Another thing, so we talked about the color. You can see on the right side, the middle new teeth are quite yellower compared to the white tooth, the white baby teeth that's right next to them. So baby teeth, I don't know if you heard about it, but baby teeth have nickname. They're called milk teeth because they are very white, very white. What I usually tell parents is, okay, don't worry about it. Your kids' teeth color will all match after all the baby teeth are gone. Some of them will ask me, can we do something about it, like whitening? Then I'll say, hey, if we whiten these 6 teeth or 8 teeth in the front, it's not going to match and it's not going to look good later. Some parents will tell me, is my child having some deficiency in calcium, whatever, you calm them down. Okay, your little Johnny is having pretty healthy diet, pretty balanced. Obviously, you do your intakes, right? But most of the time, this is quite common. I actually get asked this daily too. So I just want to mention it to you. Okay, so why are baby teeth so important? It's going to fill out anyway, right? So healthy diet means healthy growth. The baby teeth, front teeth starts to change around 6, but all the way to the second baby molar, exfoliate or fellow around 12. So you can't really expect your child have bad teeth until 12 and able to chew and eat well, right? Sometimes there's infection, pain, and I do see quite a lot of kids having trouble eating with that cavity. So healthy diet, you need healthy teeth. Good oral hygiene also means you'll have better chance of having good permanent teeth growth as well. Cavity causes space loss. So the in-between kind of cavity, if it starts in between and not treated in time, it will soften the enamel and dentin, create holes, and with function and chewing, the two teeth move actually closer and closer together. So in the back teeth situation, okay, our premolars are a little bit smaller than our baby molars, but some situation you can even lose half of the tooth width. So that's quite big of a cavity, and it happens quite often as well. So then you'll tell parents, okay, so first of all, we need to take care of the current cavity situation, and then you need to warn them in the future. We'll have some crowding situation as well because of this current situation. Healthy baby teeth also equals to healthy bone growth. If you think of an old senior person with complete dentures, upper and lower, no teeth at all, when they take the denture out, you see the ridges of the teeth short and tiny. It's because without the roots, the jaw doesn't grow as well. So obviously, if a child needs an extraction, if there an infection needs an extraction, we do need to act upon and resolve the infection and assure the parents that, well, Johnny is going to be okay, functioning okay without it. But if we can prevent this, they'll have a better growth of the jaw. The height is going to change. The kid's face grows so much, right? If you prevent decay in childhood, you avoid toothaches, infection, and most importantly, the fear and anxiety of going to the dentist. So if you can go from prevention, it's always 100% better. And we talked about some baby teeth do stay in the mouth until 12. One other thing is, when a child has better or positive dental experience when they're young, they're also more likely to have motivations carry into adulthood to take care of their oral health, not just their daily routine, right, but also more routine adult visits to the dentist as well. Okay, so first dental visit at 1 year old. This is what we all pediatric dentists trying to spread the good words about dental knowledge. And what's gonna happen? So this is my older daughter's first dental visit. What's gonna happen in the first visit? Because the child is so young, he or she may only have a few teeth. What's gonna happen? So we show parents and demonstrate, not just talk, but demonstrate what would be a good position to help little Johnny establish the routine. I'm assuming you're all college age, right? So maybe not all of you guys have kids, but most of the kids under 3, it's actually quite difficult to help them brush. Not only sometimes they're not interested, but what I talked about, the mouth is their safety or secure center. They don't want too many things in there, and they cry and fight. And so we talked about stuff that can help them incorporate a good routine at home. What could we try? What tricks? What tips? And also talk about what's the common injury. In what situation you need to call me right away. In what situation, if it's 10 o'clock at night, you can call me tomorrow. Or if it's over the weekend, Saturday, then you can call me on Monday, right? So stuff like that. And also just to create a dental home for them. So when injury or trauma happens, they have someone to get a hold of right away. I also talk about diet because diet recommendation is so important. For example, the child shouldn't drink anything other than milk or water until age 2. And it's also the amount, say like a couple ounces of what per day that we need to make sure the parents understand, because some parents, or most of them, they don't understand this and provide just juices to a 1-year-old, 2-year-old, and that will cause early childhood cavity quite often. and also the frequency and quantity of snacking. What more important is the frequency other than quantity. For example, if you have 3 cookies or 3 candies you want, the kid really wants to eat, then I'd rather you give the 3 cookies to little Johnny all together, close to the mealtime is better, but all together, versus 1 cookie every hour. So then the pH of your mouth stays low, then your cavity risk then significantly increase. So growth and development is also other thing we talked about. Fluoride. So a lot of parents don't know that they can start using fluoride toothpaste as soon as the first tooth erupts. But we also talk about, the amount of toothpaste that's appropriate for each child according to age, and twice a day. And in some very worried patient or moms, and I throw my figures out, right? Calculate, per dose and per weight and the toxin level, So really helps the parents understand that this is safe to practice as soon as you have the first tooth. We also talk about other things we could help at home to strengthen the oral health, and also to help transition a kid out of the pacifier or thumb habits. How to prepare a child's first visit. Stay positive and cheerful, because most of the adults still have fear or anxiety to the dentist themselves. So we really try to ask the parents not to project their own fear or their own experience to their child, and also just really keep it positive. And some parents will throw us under the bus. They'll say, if you don't listen, I'll have Dr. Raylien pull your teeth or something like that. Then that's really not helping me. Anyway, we can explain what to how going to the dentist looks like by showing pictures. There's tons of kids books that talks about dental visit, the common ones, the Peppa Pigs, the Paw Patrol, they all have it. So whatever your kid is interested in, the cartoon, they should have one. Role playing at home, play dentist and sit down, let your kid brush your teeth as well. Just get them familiar with the process. And also, every child is so different. Not all the kids you're gonna see very cooperative, sit in their chair at the very first visit. So really have to prepare the parents' expectation as well. And it's okay to be a little bit nervous for the first visit, and it's okay not to complete step 1 to 10. Right, little steps, every improvement is worth celebrating. And also to really watch out and know your child's routine. So if your kid is the most energetic or most cooperative, good listener and early in the morning, then do that. Most of the kids are, but some parents will tell me, no, it's about 10 o'clock, or it's about when they wake up from their second nap, or just know your child and bring them in that you think they're gonna enjoy the most. And you can also bring a kid's favorite toy or stuffy if they have something that clean too. That will help them, have something familiar with them by their side. Visit the dental office websites. Show them, most of our offices will have their, the operatory pictures or the dentist picture. The hygienist or the front desk picture, and their names as well. So when you're preparing your kid, you can say, oh, we're gonna go see Dr. Raylien next week, and this is Dr. Raylien. You show the website. Say, Dr. Raylien is super nice, just help preparing them. I also do review baby dental books on my Dear Dr. Tooth Fairy account as well, so if you're interested. Now let's talk a little bit about cavity. Am I good with time, Lori? Yeah?
You're good. Yeah, you're good.
Okay. Just let me know if it's over.
For sure, no rush.
Okay, so cavities are very commonly seen younger than 3-year-olds in the upper front area, and it's called severe early childhood caries, or other names are baby bottle cavities or breast milk cavity. And it's in the upper front area because the lips hoarded the milk over here. The lactose really gives those bacteria enough food to party over there. So on the X-ray, you'll first see along the gum line or in between. So you see in the middle picture, you see a little halo or half moon like that. They're all baby cavities. And one more thing to mention in this x-ray is in kids younger than 3, I talked about the proportion of the nerve in the roots or the nerve. You can see from the left side to the right side, probably I would say, 60 to 80% of the tooth structure is the nerve over here. So when we have a shallow decay here on the crown area, general dentists may think that, okay, this is a small cavity, but if you don't take an x-ray, you don't know it's actually so close to the nerve, right? So that's one more thing to consider when you treat young kids. We do have white fillings or what we call crowns for those situations, but for the crowns, so there's two major crowns. One is the zirconia crowns, that's newer to the market, versus resin or white filling crowns. So how do we do white filling crowns? There's this transparent foam that like pre-made. So you just select the appropriate sizes that's best for the tooth, fill the composites in there and squeeze in after you remove all the decay. So when we look at cavity in baby teeth, there's a couple big things we looked at: the kid's age, the depth of the decay, and the number of the teeth that have cavity. Why? Because age, I need to know if this cavity is worth treating. How many more years is this tooth going to stay in the mouth, right? So if it's the same exact kind of cavity, but a child is 9, and I know the tooth is going to fill around 10, then I say, okay, might as well take it out and we'll accelerate the eruption of the adult tooth. But if a child is 3 and we know the molar is going to stay there till 10, then we're obviously trying our best to save it. The depth of decay depends on what type of filling we're going to do, right? It's white amalgam or a crown, and a crown in baby dentition is usually a silver stainless steel crowns. Number of the teeth matters because if little Johnny is 5, okay, maybe he can sit through 2 visits of filling, but if it's rampant deep cavity, then we may, reconsider either mild sedation, or if little Johnny is like then we talk about general anesthesia. So if it's a hollow decay, small number, and a child is non-cooperative yet, then we also can look at silver diamine fluoride. That's a newer, I would say newer in North America, US and Canada in the past decade. It's used on cavity off-label, but it arrests the decay. It's antimicrobial, it arrests the decay, and it's anti-sensitivity. So it's used a lot for seniors if there's palliative care. Some maybe they cannot make it to the dentist, but they really need to relieve the symptoms so they can eat and have good diet at that stage of the life. Then you can apply it on the root surface so they can decrease sensitivity, or arrest the decay in this case on little kids. Silver diamine fluoride is a good temporary measurement, but it's not meant to be a permanent treatment option. So it's a good, like in the meantime, follow up, and also change their habit at home, tell parent how to change their brushing routine, diet, and once things are more controlled, the kid is slightly older, then we try the actual treatment itself. So it depends on the kid's maturation, mental development. Either we do tell due to complete the treatment. On top of that, nitrous and oral sedation is usually for a little bit more nervous kids, or if a child needs to go through like full quadrant dentistry, and sometimes it depends on how you assess the child, right? Sometimes you know based on your experience that after the second visit, the kid is going to have enough, and then the rest of the teeth, we still have to sedate them. So might as well give them a good visit, and then they will have better experience going forward. So this is an example of a self-redeeming fluoride. So you can see the black spot here on the chewing surface or the occlusal surface that we call. There's on the right side, you can see after the self-redeeming fluoride application, I do see them about 2 to 4 weeks after and make sure the decay surface is arrested. And then we place Fuji material or any fluoride releasing material on top of it to really seal the groove, prevent, recurrent decay as a temporary measurement until later. If it's stable, no leakage, great, we can probably monitor for a long time. But if things changes, then this is a temporary measurement to control the situation. Other things are, like flossing. So if this on the right side of this picture, we can see the calcification or cavity starting because we just lost the baby molar and the premolars just poked through. So we have the privilege of seeing this. But this picture I show parent a lot, and this is why we need to floss. Another quite commonly seen cavity area is along the gum line, and that's an area that's very, very commonly missed when parent or a caregiver brushes the kids' teeth. I show them and I say, hey, this is a gingivitis. I show them the picture of the calcification, but this is a great case where this pattern is very easily seen. So the depth of the decay goes from demineralization, meaning within the enamel, to enamel, past enamel to dentin, and dentin to the nerve. So on this x-ray, you can see a small shadow at the tip in between right here. But this exact same x-ray is the same patient on the left side. So on the outside, you really cannot see anything. So when the back teeth are touching tightly, and when the child is able to tolerate x-ray, I do take a baseline x-ray to go forward. I just really want to make sure there's nothing to start with. If there's indeed no decalcification, no demineralization, then I don't take x-ray very often, maybe once every year or 18 months. But if I do start seeing demineralization, then I monitor those surfaces closely because decay can travel and grow fast in baby dentition as well. So here's another example of how that little shadow progressed into the dentin. In the very beginning, it travels like a tunnel sideways horizontally, like this first picture, and top and bottom, so quite rampant. And then sometimes in between 6 months, next time I see them, they decline treatment, right? When the cavity goes into the dentin, we do want to intervene. But they decline treatment and say, my kid's teeth looks fine from the outside, and next time you see them, it blows out like a balloon. So that's like the middle picture here. This x-ray shows what I talked about, the shadow or the infection in baby dentition that you see is in between the roots. It depends on the situation of that tooth. If it's that tooth is still alive, then we can treat the cavity, what we call the pulpotomy, meaning just remove the nerve in the crown portion. This is not my work, by the way, but it's a great example. Versus in adult dentition, what we commonly hear the root canal treatment is to remove all the nerves, so all the way down to the apex or the tip of the roots. Let's see. So some parents will question your decision. Can we just do a huge white filling instead of a pulpotomy, a nerve treatment, and a crown? I'll tell you, how do I say it? So different parts of the world will have different treatment philosophy. But here in North America, we do follow what I just told you guys, right? When it's closer to the nerve or even into the nerve, then we prepare ourselves for a pulpotomy and a crown. Some general dentists, because I have to tell you, not all the school will give you enough experience to treat kids even during the 4 years of dental school. So some general dentists, they're not aware of these concepts, and they will treat large cavity with large white fillings or silver fillings. So on the left side, you can see this big thing is our large filling that's into the nerve. And it's not very clear here, but you see how this root is kind of cut off here, and that's resorption and infection happening there. And same situation here. So this white filling has a step, right? So this GP or this dentist, from the top, you can see, okay, it's quite well, they're touching, they have enough symmetrical shades over there, but underneath the contact, because the cavity was so big, the two teeth moved closer together. So on the bottom here, it's actually wedged underneath the contour. Remember I told you about the constricted neck of the tooth? That's where it runs into trouble. So the general dentists try their best to restore the tooth, but there's a gap. And as well as you see the tip of the depth of the filling went into the nerve. So it triggers a whole infection here. You see the black? That's a big infection. It's this tooth. It either needs a full root canal treatment or it's going to be extracted. So if we could start over and treat this tooth with the pulpotomy and a silver crown, this tooth would have a very, very high chance of surviving until the end. So this is an example, a picture of how it looks like in the mouth, a stainless steel crown. This cartoon on the right side shows us what will happen if we don't do a space maintainer after removing a tooth. Then your premolar will be blocked. So it depends on the age and the location of the tooth that we're going to remove. There's different types of space maintainer that we do. Okay. So regular checkup and x-rays are so important. So we talked about an extra tooth. Sometimes you don't even see big gaps. And on a routine x-ray, you see this extra tooth. So on this picture, on the left side of this x-ray, it shows 1 and 2 extra teeth. And sometimes extra teeth pointing downwards, that's easier to manage. Sometimes they point upwards. That's never gonna erupt, never gonna, sometimes they also move upwards. So in rare situation, some case study, you do see it coming out of the nasal cavity, stuff like that. So if you can catch that early on with an x-ray, it's all like, it's easier to manage, I should say. Most of the parents are worried about radiation nowadays, so you can tell them, okay, compared to eating a banana, flying from New York to California, you'll have like way more radiation than a dental x-ray nowadays. So your radiology class in dental school will tell you all this new technology, the shape of the cone, the size of the film, the speed of the x-ray is all going to matters in terms of the radiation that we reduce today. This is another picture that shows the incidental findings. So this kid, I believe it's 17 when he came to me for the first visit. He moved and came to me, and I said, have you ever had this big picture taken a year to the other? He goes, no, never. Mom said, no, I never had this picture. So okay, I took this panoramic x-ray and I saw this round thing staring at me, basically. What is it? It's a mesial dent lying horizontally, pointing out of the mouth. So I immediately referred him, and the oral surgeon took it out. So just because it's not causing problem doesn't mean that it doesn't need to be taken care of. So you can see that this extra tooth is causing the central incisor on the side to have very tilted roots. In this case, there's no infection, but other case, an impacted tooth can cause what we call odontogenic cyst, or other more severe things can happen. And it's always easier to treat it earlier than later. Then the body's healing capacity, right? The way you refill the bone are different. So this is another x-ray example for a congenitally missing tooth. So this you will not know unless you take an x-ray, right? So in this case, I can say, hey, mama, the little Johnny is missing 2 adult teeth here. We need to work closely with the orthodontist to, plan ahead. So make sure his occlusions are right, And then lastly, just a little bit about diet and the amount of sugar that's actually in. So for example, most of the juices or orange juices say 100% orange juice, but you really need to take a look at the label. A container of this includes 11 teaspoons of sugar. Can you imagine give your child a cup of sugar and just dump it in their mouth? It's equivalent to giving them juices early on. So you really need to quantify it and display it with a visual aid to help educate the parents about this type of things. Even the sports drink, vitamin water, let alone soda, but tea, it's so much sugar. So we also talked about what's healthy, what's not, right? In between meals, it's best to have less than 3, up to 3 snack time for kids younger than 6. Yogurt, cheese, nuts are all healthier diet, or fresh fruits are great. Okay, so what I usually tell parents is the basic thing is to brush twice daily, use fluoride toothpaste. On the left side is just kind of my page if you're interested. Use fluoride toothpaste, have parent-assisted routine. I tell the parents, you need to help your child to brush their teeth until they're 8 to 9 years old. It's so important because kids, even though they seem like they're doing it, they really don't have the dexterity to really clean all the corners and the edges of the dentition. So a parent-assisted routine is so important. For young kids, laying down position is the best. So you can see a little bit of cartoon on the left side how I prompt and help prepare my kids for their routine. Because when they're laying down, it's kind of like in your dental chair. You can see much better. You have better access and better control of their head. On the bottom jaw, you see it right away from the back. But for the top, you'll ask them to tilt a little bit upwards, and you can actually see their entire upper jaw. And I'll show the parents how to use both of their hands to complete a routine as well. The use of dental floss, I'll also show them. Mouthwash wise, your kid needs to be able to know how to spit first before using mouthwash, and that's it depends on the child. Some do start learning it around 2-3 years old, but it has to be very consistent. So usually around 4 to 5. And regular checkup every 6 months, not only to help establish their routine, because it also is a kind of a series of desensitization for your kid to grow up in this environment and habits for their prevention as well. Okay, so that's it. Please follow me on Instagram if you like my presentation, and I do post educational posts often, so I hope you'll learn with me. And if you have any questions, feel free to reach out to me through email or Instagram. And if you're in Vancouver area, feel free to visit.
Thank you so much, Dr. Raylien Chao. That was a super informative presentation. I'm sure everyone watching learned a lot about pediatric dentistry. I know I did. We do have some questions in the chat that we get to if you'd like. Mm-hmm. So what made you want to specialize in pediatric dentistry?
Mm-hmm. So I actually was in between general dentistry and pediatric dentistry, because they're very similar. So they're both comprehensive care. If you think of it, it's just comprehensive care to a different population or age group. I was in dental school, and my school requires quite a lot of requirements for pros, meaning making dentures, so partials and complete. So I have no problem making it. But through the first 5 cases I did, my first upper and lower complete denture case was a girl in her 30s, heavy smokers. I don't know, there could be other significant medical history as well, but complete denture at such young age, and I made her new teeth. She was so happy. She said, I wish I knew how I had known how to take care of my teeth when I was little, because it could look the same, but it never functioned the same. So dentures, even with the implant supported ones, it is never going to function the same as your own teeth. So dentures can wobble, there's a lot of things beyond that, but what really draw me into that is my experience making dentures and how those patients react. They're so happy with their new smile, so satisfying, but they all have the same feedback, is wish I had known. And then it truly need to start from really ground age. So that's what brought me in. And I love kids as well. I don't mind playing with them, but I have to tell you, it's not always fun. You have a lot of crying kids and a lot of also difficult parents as well. You're managing both the parents and the kids, so it's not always easy, but it's rewarding for me, for the right, if you have the right motivation, and if you're like me, you'll enjoy pediatric dentistry.
That's super interesting. That's cool that you found that way of getting into it. I'm sure your presentation might have sparked the interest of other people too. So since you worked in Vancouver and graduated from the US, did you have to get relicensed over there?
Yes, I do, and it's quite of a process. So I had to retake their board exam. So for me, back at the time, I took their general dentist board exam, and then I took the certified specialist board exam. And back in that time, the certified specialist board exam was $6,000, and I think increased a little bit since then. But yeah, it's kind of a process.
Was that hard to take?
Yes, hard. Yeah, I think they changed some formats now, but it was written, not like in the US, you can go to an exam center and click on a computer. But their board exam was an in-person written. So everybody flew to Toronto to take the exam same day in the same. Yeah.
Interesting. What's the most common procedure that you perform as a pediatric dentist?
If you ask me procedure, I'll tell you our bread and butter is the recall and exam. Meaning healthy checkup, routine exam, play with the kids, make them happy, make it fun. And on the side is the treatment. Probably about 30%. Yeah.
Cool. And which one do you prefer? If you do prefer any.
Maybe the recall, because then you're really having fun time with them. I really don't mind doing treatment as well, because that's where you show off your behavior management, and that's how you alleviate their anxiety the most as well, right? In my office, I do practice hard tissue laser. I didn't put it into the presentation, but hard tissue laser is a CO2 laser that can prep both the soft tissue and the hard tissue. Another thing I should include in my future presentation is the lip tie and tongue tie. That's also quite big in pediatric dentistry as well. But the hard tissue laser can prep the teeth, prep the decay, and do the filling without any needle and numbing. So that's
that'd be really helpful for that'd be really helpful for kids, I'm sure too. And then someone just asked, why Vancouver?
So my husband is from Vancouver, so I was really upset actually. This is gonna go to the internet and forever, but in the very beginning when I moved, I was a little upset because things are a bit more expensive here. House is a lot smaller, but adding 2 zeros in the back, and right before I moved, I was in Florida, so it's a very different weather as well. I love the ocean, I love the weather, but I appreciate Vancouver so much now. I have a family. It's very, very family friendly, and you have the water and the mountain. There's such different family activities that we can do here. So I grew into the city, but that's how he imported me.
That's great. So why do some adults still have at least one baby tooth?
Okay, so there's a case that I showed you guys where there's a congenitally missing tooth, meaning the tooth didn't form at all. Some baby teeth, if it's missing successor missing a permanent tooth, it can actually stay there as long as it can if the patient or the person brush and takes care of it. But some situation, even without the permanent tooth, it still can get resorption and fell out. So if there's a congenitally missing tooth, what we really need to work with the orthodontist or us as a comprehensive provider is to see, monitor with time to see if there's any resorption that's observed, mobility of the tooth, if it's holding well, pretty well, then if dentition, if the occlusion is fine, we could monitor and keep it for a long time.
Cool. I didn't know that it could stay like for that long, but
it could. Yeah, it could. I remember in dental school, I saw a patient in his 50s still have a baby tooth.
Oh, really? Was it just underneath the adult teeth, or was it actually in the mouth? Like
in the mouth. So in the mouth, it just never fell out as a baby.
Oh, okay.
It didn't have an adult tooth under.
Interesting. So how do you keep kids still in the chair while doing a procedure? I think that
lots of distractions. Stories, wiggle toes, play games, right? So I said, do you want to play a number game or animal game? No, they'll be like, animal. Usually they pick animals. And you'll say, okay, I'll describe an animal. You'll tell me what it is. So this animal has long nose, big ears, really tall and heavy. They'll shout out, bah, 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 or gray in color, elephant, or, just kind of things to talk about, always, nonstop talking.
Yeah.
Some kids, you do have to rely on the TV on the ceiling, the show they're watching. Each child is so different, and some older ones will tell you, yeah, I don't want music, I don't want anything, I want a quiet room. Older ones will tell you this, but just really let them listen to them as well, even though they're kids. Like my 2-3-year-old, they are able to negotiate. So like, put my clothes on, but I said, okay, what do you want to do first? I want to read a book. Okay, after you read a book, you're gonna put your clothes on. Yeah, and it actually happened. So just listen to the kid. If you say, hey, I want a break every 15 seconds, okay, then we count to 15 and we'll give you a break. But the way you count to 15, you could be creative, right? So it's 1, 2, wait, hold on, did you go to school today? Da, 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 da. Oh, okay, blah, 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 and talk about that. Okay, 3, 4, 5, stuff like that. Just be creative, and even though they think it's 15 seconds, you're counting to 15, but you can really buy some time for yourself with other stuff that you do.
Yeah, that's a good way. Is that the same for kids who are having like anxiety or giving you a hard time for like doing fillings, I guess?
Listen to them and try, and they'll tell you.
Yeah. So how do you keep baby teeth aligned to prevent cross bites?
Okay, so crossbite, there's a few different components. It could be the angulation of the teeth. That's not a true, I don't know how to say it, but it could be the angulation of the teeth, or it could be the actual jaw position. So if a child in a jaw position is very genetic. So if you see parents' profile, they have this what we call a concave profile or a class 3 profile. Their lower jaw tends to look a bit more forward. Then it's not a surprise to you that the child may follow the similar growth pattern. So it also depends on the severity of it, because lower jaw is from what I read, the last job to finish growing in our body. So like teenagers, especially boys, if they have this tendency, most orthodontists will wait, because their lower jaw could all of a sudden like grow, just tilting the teeth a lot to try to jump the crossbite, but you're not giving a patient's teeth the best position, because if you tilt it too much, then the root of the tooth is not sitting in the jaw in the correct or the best position, then you're causing more harm than good. So you really have to assess the child's growth pattern, the whole situation. If it's one tooth, then it could be the habit in the past, it could be the space that's currently not enough, and maybe if you follow up with the growth, it will self-correct a little bit. So yeah, it's a big question to answer, but the two big category is either dental or developmental.
Okay, and then that, I guess, shows that it's really different for everyone.
Yeah, the way you deal with it is also different as well. Yeah, some dental crossbite, you can help correct it as the adult one erupts along with growth, and others, if it's a full segment, then it's another story, right?
Okay. What age can a kid wear braces? Like, can they start, or would you recommend usually?
When they're too young, and it's what should I say, like first assessment around 7, because at that time you're just starting to have adult teeth. It really does not make any sense to put braces on baby teeth. First of all, the kid will be so young, you're running into cooperation and also traumatizing the kid as well, even though he or she can sit through it. It's not going to be a fun visit to wear that at such a young age. And most of the situation can wait until after the teeth are done changing. So there's 3 different alignment situation in teeth when we categorize the occlusion. One is class 1, which is the most common. Class 2, meaning the lower jaw is really stepped back. And class 3, meaning the lower jaw is really moving more forward. So in a class 2 situation, it tends to be quite stable until they're done changing. So in those situations, we tend to wait until the end, unless the gap in between the upper and lower front teeth are really severe. Then we do phase 1 treatment to decrease that space, maybe for aesthetic, but also to decrease the risk of trauma to those front teeth that we talked about. In a class 3 situation, it just depends on when you assess the child, the growth pattern, and assess the growth pattern with some x-rays. There's different things we look for to assess those things. But big guideline for phase 1 treatment, which is younger, maybe in between 8 to 10, is when you have a true crossbite. So if it's crossbite in the front or crossbite in the back, sometimes you need expansion, right, of the jaw. So you can think of upper jaw as a garage, and the lower jaw needs to park inside. So if your garage is too narrow, you have a crossbite because the kid needs to bite, he needs to chew, you need to park the car in anyway, you need to park the car somewhere. So then your tire is sticking out because the parking spot is not enough, it is not wide enough. So in those situations, we do expansion of the parking lot, so the car in smoothly. So that is quite nice if you take advantage of the growth, versus if you see the same crossbite in a 30-40-year-old, then that's a surgical case. You need to literally split the upper jaw. So the upper jaw fused together like 2 bones, but the lower jaw is 1 bone itself. So you can split the suture and surgically when we're older, but in kids, when you adjust that, the suture fill with new bone automatically. So when you have crossbite, or if a child has affected, low self-esteem because of the way their teeth are looking, either crowding or other things. Yeah.
So again, with that, there is a bit of the variety with the different. So I just have one more question for you here. And that was, do you have any tips for anyone who's wanting to go into this specialty or just dentistry in general?
I say that you do have to love interacting with people, love working with your hands. That's most of my colleagues, but occasionally I'll I don't know them myself, but we have some dental forum, and some people will say, I'm done with dentistry. I'm in it for the business side of it. Maybe you're interested in income or whatever. But if you really don't have that motivation, you will have a really hard time in this profession. If you look into the suicide rate, I think dentists is a number one for quite a long time, and I do know personally two dentists that I know of that end their life. So it's like you need to have a good life balance, and it's as a dentist itself, I love it, right? I encourage all people who's interested to go into it, but you do need to explore. I would say do some shadowing, right? Visit your local dentist to see how their day is looking like in a day, and also talk to the dentist about out of the office as well. But you do need to love it to do it for a long time.
Yeah, I'm sure. And thank you for those tips. And yeah, I feel like with any job, you gotta love it if you're going to be doing it every single day.
Yeah. I feel so blessed.
That's great that you do love it. So, again, thank you for your presentation, and thank you for everyone who came out today. I hope everyone has a great rest of their day.